Hi there, my name is Barry Benson, and I'm a student at the College of Nursing and Health Innovation at the University of Texas at Arlington. This presentation is for my Nursing 5342 Management of Nursing Operations class. The professor is Dr. Candida Constantine Castillo. This PowerPoint was created July 24th, 2026, and today I am here to talk to you guys about an observation oncology unit strategic and marketing plan that I am proposing. So, when we're discussing the facility that we're proposing implementing this unit on, we're going to implement it in Tucson Suburban Hospital. This is a 500-bed facility that has been open since 1958. Tucson Suburban Hospital is located in Marana, Arizona, which is one of the fastest growing towns in the Tucson metropolitan area. It's more of a suburb of sorts, but it is one of the fastest growing regions in the Tucson greater metro complex. TSH is a National Cancer Institute designated cancer center. In addition to our oncology services, we provide women's health services, pediatrics, neurological care, cardiovascular care, orthopedics, and of course, rehab services. The observational oncology unit would provide a short stay oncologic related therapies and procedures for our oncology population. So when we're talking about the patient care model, we would be using a total patient care model. Staffing ratios for this unit would be 4 patients to 1 nurse, and we would run 8 patients to each tech. Of course, we'd have a charge nurse that would serve the floor for unit coordination, leadership, and as a resource to staff. We would want to keep this charge nurse out of patient assignment and have them be a resource and a bed coordinator role, serving more as a leadership role than a frontline role. The unit would operate 24/7, 365, and of course, we'd have a unit manager to oversee the unit. So how would we do this? Well, we would renovate 8 of the 28 beds that we currently have on our surgical oncology unit, and we would convert them to these short stay rooms. Our focus for the design of these rooms would largely be infection prevention and mobility assistance. We'd expect this renovation to take 18 to 24 months. Year 1 of the project will be dedicated entirely to renovation. So when we're looking about revenue generation, we're discussing revenue later. Please remember there is a gap between when we begin reno and when we actually start to see some revenue on the back end. So continuing our strategic plan, we do need 10.8 FTEs of RN labor because we have an organizational PTO factor of 1.2. That will get us staffed 24/7 and will allow us to have 2 nurses 24/7 to staff those 8 beds with the additional PTO factor factored in. We would need 5.04 FTE of PCT labor for the same reason. We have a PTO factor of 1.2. So we'd start hiring after year 1. We know the renovation at the bare minimum will take 16 months, I'm sorry, 18 months. That's as low as the renovation can possibly go in terms of timeline. So we don't want to start hiring too early because what are we going to do with these nurses? There's a little bit of a plan for that coming down the road, but we want to still be as responsible as possible, even if we do have a plan for what to do for our unhomed nurses, so to speak, until the unit opens. So as mentioned, we'll begin year 1 into the project. RN staff will be trained for the short stay unit, but we will orient those staff in units that are currently understaffed, right? The unit's not open yet. And if we're hiring people like new grads, we're going to need a place to teach them basic nursing skills that can be applicable in the oncology short stay unit. So we're going to take a look at some units that have some understaffing issues. They might be relying on contract labor. They might be using a lot of OT, whatever that looks like. We're going to orient those units in that place, and then we're going to have them be productive on those floors until the short stay oncology unit opens. And we'll be upfront about that when we're doing the hiring process for this unit as well. PCT staff, we're going to wait until we open the unit fully to hire them. The training curve is not quite as long for PCTs, so I don't see as much value in bringing them in earlier in the process. We'll wait until we open to bring them in. We expect our RN labor costs to be $28 an hour and our PCT costs to be $9 an hour. So we're going to talk about some of our reimbursement models and what we expect to see. So reimbursement for this specific type of setup is on the CMS schedule for $4,000. It's $4,684 per inpatient day. When year 3 happens, and year 3 is the first full year we'll have with the unit fully open, we do expect to see 1,275 inpatient days based on national performance with like units in similar environments. We're looking at other units that have an oncology short stay unit and a similar population demographic and with a similar suburban kind of setup. We are expecting a 12% annual growth for years 4 and 5. So the second and third year that the unit is fully open, based on, again, like hospital performance. At the end of year 3, however, the first year fully open, we expect enough total revenue to be slightly over $6 million. When we factor in the anticipated labor costs and renovation costs that we're incurring in year 1 and 2, we actually expect a positive project margin of nearly $5 million. Now, that's not revenue, that's margin. That is after pulling the cost out of that, we will have a $5 million windfall or positive operating margin. So a brief SWOT analysis on this. I mean, our strengths of this proposal, we're going to decrease length of stay, right? That's a big proponent for fiscal solvency and financial health. We're going to try to reduce utilization of the emergency room. I mean, a lot of these patients that need a quick tune-up, they need fluids, they're nauseous, they're whatever, they have to go to the ED to get that care now. We're going to try to pull them out of the ED and get them in these short stay spaces. Alternatively, some of these diagnostic procedures or operations that they have can be short stay procedures. And, we can do those procedures and we can free up PACU spaces and some of the other operational spaces. And then, of course, the biggest reason to do this, these are our oncology patients. They don't want to be in the hospital. They want to be home. So we're focusing on getting them home faster and improving their quality of life and the perceptions of their care. Weaknesses, and I'll fully acknowledge this, the upfront cost and the delayed revenue generation can make this kind of tough to swallow. I get that. We're going to invest a lot of money and we're not going to see a payoff until possibly 2 or possibly even 3 years into the project. And that can cause some challenges. Other weaknesses we have, this is dependent entirely upon an oncology population. Now, there's no indicators now that we'll see any decrease in our oncology patient population. However, it's always a risk and worth mentioning. In terms of opportunities, if this unit is successful with the 8-bed model that we have, we could potentially expand this to other short stay, appropriate patient populations and other service lines that could benefit from a similar short stay setup. Some of our threats, we are close to the Mayo Clinic and Banner Health. In Phoenix, they do have a chance to grab some of our market share. It is generally kind of my opinion that people that are looking for high level care like that for oncological services usually have very complex diagnoses. They have complex treatment plans, or they have a complex disease course. And those patients typically are not going to be the type that we would expect to see in the short stay unit anyway. We're expecting people with normal treatment regimens that are having, the sequelae associated with cancer. They need to tune up, they need something to feel better, and then we can get them home, or they need a diagnostic test. For our patients that are wildly complex, I don't think that the short stay unit would be appropriate for them. And I don't think they'd be as eager to drive all the way up to Phoenix to get to Mayo Clinic or Banner. But again, it is a threat and worth considering. So let's talk about the marketing plan. Marketing theme is to provide fast and high quality service that returns patients to their lives as quickly as possible. That's kind of the theme of what we're discussing here. We're going to run a 3-pronged marketing plan. We're going to run some billboards along the freeway on and off ramps at the I-10 Marana exits, so people in the town of Marana can see those billboards. We're going to run banners alongside the Tucson Suburban Hospital campus promoting the unit, and we're going to do a limited 5-month Google advertisement promotion. We're going to use appropriate oncology related keywords and search findings to do that. So in timing of all this, the banner is going to go up 1 month prior to opening with, the coming soon. We're going to have this unit, yada, yada. And then once the unit's actually open, we'll transition to, hey, congratulations, the short stay unit's open now. Come on in if you need to get a tune-up, if you need to get some care. And we'd run that banner for about 3 months. The billboards, we're going to hold until we're actually open to deploy those. And we'll run those for about 3 months once we're open. The Google advertisements, that'll begin 2 months prior to opening. And we want to focus on both recruiting staff initially, and then we want to convert it and make it more patient focused. So 2 months prior to the unit opening, we're going to start the Google advertisements. Month 1 of those 2 months, so 2 months prior to opening, it will be staff oriented. Hey, come work here. This is what this unit's about. This is what you can expect. This is why we're excited about it, so on and so forth. Then as the unit opens, we're going to shift focus to patient, right? So this is why you want to come to this unit. This is the services we offer. This is what you can expect in your care here if you come in. In order to design these marketing, we're going to work with our patient family advocacy committee. That way we can get actually some community stakeholders to weigh in on what would be important to them. We're going to work with information technology, obviously, to help design a lot of the Google stuff that we're using, finance, to help us fund it, naturally, branding and marketing, and talent acquisition. We're going to look at all of those parties and collaborate with them to make sure that we're capturing everything as we begin this marketing campaign. So let's talk about the expected revenue. This is the scary slide, right? 2027, year one, we don't see any revenue generation at all because we don't see any patient volumes. This is just a flat line. We are incurring some costs here, but there's no revenue generation. Going into year two, we're going to make the assumption that the unit opens up at the earliest possible time, which would be 18 months, right? So we start to see some volume and we start to see some revenue generation. We've got some dips in, the early summer when it opens, or midsummer when it opens, and then early fall. A lot of our providers are on vacations, nurses are on vacations. We expect some decrease in flow, and a lot of patients are trying to avoid the hospital at that time. Year three, this is year three. This is a year fully open. Again, we mentioned what we expect in terms of patient volumes and associated revenue before. We do have that dip in the summer and dip in the winter when we expect some providers to be out, and we might see some services decrease. Also, patients are trying to spend time with families, and they're going to try to avoid the hospital the best they can. They may not be able to, but I know historically they'll try. So this is based off of some historical trend data that we see in other like organizations and based on our oncology service volume. So in summary, while the upfront cost and lack of revenue is concerning, the project will create a positive margin at year three, barring any wildly unexpected events. Patients in this region, they don't have access to a service like this. And a service like this is very regional centric, right? People aren't coming here to get the craziest, most advanced, scientifically proven cancer. They're coming here because they want to feel better fast. And when you want to feel better fast, you're going to look to a close location that can help you out. So that's exactly what we're trying to provide here. The short stay nature is going to help keep costs down and satisfaction scores high. And then to further keep an eye on costs, we can deploy staff to less supported areas while waiting for the unit to open. And that'll help offset a lot of those labor costs associated with year one and part of year two. This is the part where I normally stand for questions, but I don't think you guys are able to ask me any. I hope you enjoyed the presentation. I hope you have a fantastic rest of your day, and thank you so much. Here's some of the references that I used to make this presentation, and I look forward to your consideration and your decision about this proposal. Thank you so much, and have a great day.